You are listening to the Addiction Files, where we discuss evidence-based treatment, clinical pearls, and resources while striving to destigmatize the treatment of addiction in our medical culture and save lives. We are the Addiction Doctors, Dr. Darlene Petersen and Paula Cook. Welcome to the Addiction Files. We are thrilled. Tonight, we are going to discuss harm reduction in treatment in the correctional settings. And this is a presentation given by Dr. Paula Cook and Lanette Denton. And I am so thrilled that we get to have you guys, our own Dr. Cook, giving her presentation, joined with Lanette. So I'm going to turn it over to you guys to give an introduction, and then let's get started.
Great. Well, first of all, Lanette, why don't you introduce yourself, just because people don't know who you are? Just tell us a little bit about who you are and what you do, and then we'll talk about the topic and we'll kind of go from there.
Thanks, Paula. So I'm Lanette Denton. I'm a peer support specialist down here in Moab, Utah. I have been in recovery for about 10 years now, and started working for USARA almost 7 years ago, and I'm loving it. And love working with Paula down here, and that's who I am. And thanks.
Amazing.
And Lanette, just tell us a little bit for some of our listeners, because we have ones all over the United States and international. What is USARA? Just explain that a little bit, because that's not a term familiar to everybody.
USARA is Utah Support Advocates for Recovery Awareness. So it is an organization, a nonprofit organization that is a recovery ran organization that's mission is to connect and inspire communities to advocate for addiction recovery.
And they're amazing. You guys do an incredible job. And I hope every state has an organization like USARA. It's amazing. All right. Well, thanks, Lanette. Thanks for joining me. And Darlene, thanks for having us do this topic tonight. We're really excited to present this topic as a podcast. We're getting ready to present this topic at a national addiction medicine conference. And so we're ramping up, we're getting ready and to present in that setting. And we were so excited about the topic, we wanted to actually just publish it as a podcast episode. I have to say personally that the more I started to research about this issue, the more passionate I felt about it, and the more kind of, I guess passionate is the word, just like, oh my goodness, this is such a huge issue. And it's not something we really talk about too often, even those of us who are in the addiction medicine, addiction recovery arena. And I think that's just because incarcerated people are even more stigmatized than people in recovery or people with substance use disorder already. So we put people who are incarcerated, that's another level of stigma. We put people who have substance use disorder in incarcerated settings, more stigma. And then, of course, when we look at the data, many, many more people of color are incarcerated than white people. And so we just layer up these things, and we find that they often are not getting the same treatment and the same care and the same concern, in spite of increased risks that the rest of us are. So it's time for us to step up our game. So let's talk about incarcerated populations and substance use in the US. So in 2016, which was a couple of years ago now, which is the latest data I could find, there were about 2.16 million people incarcerated in either state or federal prisons and local jails in the US. So 2.16 million people, and an additional 4.5 million individuals under community supervision. So that would be probation and parole. So a lot of people, and I think we lead the world's population in terms of incarcerated populations. And we have a really disproportionate representation of Black and Latinx populations in our correctional settings. In fact, the imprisonment rates for Black adults in the United States was nearly 6 times the imprisonment rates for whites, and nearly double the rate for Hispanic adults as well. So I mean, this is just horrible. Darlene, we need to do a whole episode more on racial disparities in substance use. But I mean,
yes,
this is
absolutely.
a really dire statistic. We also know which I wasn't aware of. I mean, I was aware that people of color were way more likely to be imprisoned, but I was not aware, and it makes sense that Black people are much more likely to be jailed for longer than white people. So that's distressing. People who are incarcerated are more likely to have physical and mental illnesses than the general population. So we actually know from some data from the Bureau of Justice Statistics that 44% of the people who are incarcerated have a mental health disorder. And compared to the general population, people of both sexes are more likely to have chronic medical conditions like hypertension, asthma, cancer, arthritis, chronic pain, infectious diseases such as tuberculosis, hepatitis C, HIV, and STIs in general. And actually, women are represented more highly than men when it comes to chronic illness and especially sexually transmitted infections in the incarcerated population. And there's been some really interesting work looking at the disrepresentation of females in incarcerated settings when it comes to STIs, HIV, hepatitis C, and whether or not they're receiving treatment for these things. So when it comes to substance use disorder, I mean, I don't know, Lanette, we've talked about this to the jailers in our local jail. And Darlene, you're familiar with working with people that are in the correctional system, but it feels like so many people in the system have a substance use disorder, and we're right. Because about 65% of people, according to the data, have an active substance use disorder. So they meet criteria for a DSM-5 substance use disorder, the time of arrest. An additional 20% of people were under the influence of drugs and alcohol when arrested, and their crime is secondarily or primarily related to the intoxication. So there you go. You've got 85% of your incarcerated population somehow either actively with a substance use disorder or incarcerated related to a drug and alcohol event. So, I mean, that's huge. 85%. I don't know. That kind of blows me away. So one of the things that's really concerning, and this is what led us to kind of do our presentation, and I think we've heard about this in the media, and that is that the overdose death rate for people on release from prison or jail is 40 to 50 times the rate in the general population. And this has been studied in multiple settings. And it was interesting to look at the data on this because some studies say 40, some say 50, but there's nothing less than that. I mean, this is a 40 to 50 times increase rate. And the most common cause of death of inmates for up to 4 years after release of their incarceration is overdose by a substance. So this poses a huge risk to people when they're leaving.
These are terrible numbers.
That's
just terrible.
I know, right? Doesn't it make you mad? Okay,
Yes.
so we're talking about the risks. So who's in prison and jail? And we're talking about the risk when they leave. So we know that the overdose risk is extremely high, and there are reasons for that, right? People lose tolerance while they're incarcerated. People think that they can resume using right when they get out. People have withdrawal and cravings and want to use when they come out. People aren't offered treatment when they're in jail and prison. I don't know, Lanette, can you think of any other reasons why people are more likely to resume use in a dangerous way when they get out that I'm not thinking of?
I know that, like, for me, one of the biggest reasons for me to use as soon as I got out of incarceration, it's really generational where I'm from. And so as soon as I would get out, I would go right back to it being a home and with my family. My entire family struggles with substance use disorder. And so I really couldn't get away from it, no matter how badly that I wanted to. And growing up here in this community, it can be generational for a lot of the folks that struggle with it here. And so I think that would be something.
Yeah, that's such a good point. And I treat a lot of patients coming out in a residential reentry center. And that's a common theme that I hear is it's just everywhere. It's in your community. And even though they may come out and have a period of sobriety, it's so hard to come back to that community and it's such a struggle. So that's one thing. And it's just like you said, when there's lack of resources, and then they're dealing still with a lot of these negative consequences of their use. Just because you're released from incarceration doesn't mean that you still have to find a job, and you've got probation and parole officers and everybody like with their finger on you, and a lot of stress and this adjustment. And we've talked about this before, but a lot of adjustment anxiety, and even if they don't have already very serious mental health disorders that aren't being treated and haven't been treated for most of them, like what you just said, Paula, while they've been incarcerated, they're coming out with usually untreated mental health disorder, and trying to deal with all this acute stress of trying to just reintegrate into society. It is just like you've got the card stacked against you. And then it's just like, and just try and stay sober. That's what it's hard.
Yeah, you're right. There's so many social factors, like you're saying, and like Lanette said, it's generational. You're often going back to the same situation you were right when you got in, or worse, right? You've lost your job, you've lost your home, you're now in more trouble, you're in probation, you're under parole, you're being scrutinized, you have lack of financial resources because you couldn't pay your bills, all of those things.
Let's not forget the felonies.
Oh, let's not forget the felonies that then prevent you from getting.
Yes. So you can't find a place to live because you've got felonies. You can't get jobs because of that. I mean, it's a really serious thing that no one really talks about, of what a struggle it is.
Yeah. It's very hard. Yes.
Tough. Well, let's talk a little bit about, what about the substance-related harms while you're incarcerated? I mean, the harms don't only exist when you leave. Prison and jail is no picnic, right? And we know that drug use continues in these settings. Risky drug use continues. There's violence, there's assault, there's all of these things. So there are some really good papers that have been published looking at the rates of fentanyl-related overdose during incarceration. People overdose while they're there because they have access to drugs, and or they very commonly will overdose within the first 24 to 48 hours because they may have swallowed their supply when they were approached by law enforcement, and then their supply will burst in their gut, or they took too much and they didn't metabolize it, or they stashed drugs going in knowing that they were going to be out, and they overtake their supply. There is commonly risky needle and syringe use in incarcerated settings, and there's a black market drug supply which can drive risky behaviors such as HIV contraction, acquiring hepatitis C and hepatitis B, amongst other things. And then I mentioned violence briefly, but violence remains a huge threat for people that's surrounding substances. And I mean, I just feel like, Darlene, you and I are on the periphery of this as providers. We hear some stories, but there's only really people who've been in these settings that really understand what this setting is like. Okay, so just to give you a little bit of data on this, the top 3 causes of death for people while they're in jail. Lanette probably knows because she probably knows because she knows these things. But Darlene, you may have not seen this presentation, but can I put you on the spot and I'll give you a guess? What do you think the top 3 causes of death are for people in jail?
Well, I reviewed this and I don't know if I remember them in order, but I was really shocked that suicide was like in the top 3.
Yeah, suicide is actually
awful.
number 1. Yeah, suicide is number 1 cause of death for inmates, which is just so sad. And it's a significant cause of death on release as well. And
you have overdose.
Overdose
for the reasons you just said.
Exactly. Yeah. And overdose, and that actually includes alcohol poisoning as well, and alcohol-related ills. That's the third leading cause of death. And then heart disease is the second, which is not too surprising, considering risk factors. But, there are definitely harms in jail. And I don't think we can underestimate the harm of suicide and the risk of suicide.
It just takes me back to the feeling of when I was in there, and, I listen to folks as we're in there now, and just how unbelievably sad it is, and the darkness of when you are in there and the feeling of losing everything. And it just doesn't surprise me that those are the top reasons.
Yeah, terrible.
That's why you're in there. Yeah, it's horrible.
Yeah. I mean, it's a human rights
Exactly.
issue, isn't it, that people have these issues? I mean, the other two things to note is a third of incarcerated people have chronic hepatitis C, a third. That's a lot of the population. And we have to ask the ethical question of whether or not they're receiving treatment. This has a lot to do with payment and whether or not, especially prisons, are choosing to treat their population of chronic hepatitis C. There have been some really interesting class action lawsuits of prisoners who have lived significant amount of time in prison with known hepatitis C without treatment to come out the other end and have end-stage liver disease or worse, and they're now suing the penal system for not treating them. I mean, incarcerated populations have a right to the same standard of healthcare services as the general population. It's a human right. HIV at least 3 times higher than the general population in incarcerated settings. So we have a lot of harms when people are in jail and prison, and we have a lot of harms as they exit. So let's just focus and narrow back down to actually the treatment of opioid use disorder specifically. I'm not going to talk so much in this podcast episode on alcohol use disorder and alcohol withdrawal in incarcerated settings, although that would be a very interesting topic for another day. Treatment of opioid use disorder in incarcerated settings is really interesting. We know that if you treat people with MOUD, so medications for opioid use disorder, while they're incarcerated, it reduces post-discharge deaths by 61% in the year following release. And that in one statewide program that was implemented, I think it was Rhode Island, they actually reduced their overall state opioid overdose deaths by 12%. The whole state rate decreased by that amount just by implementing a statewide program where everyone in the jails received MOUD if they desired it. Currently, according to NIDA, only 5% of people with OUD in correctional settings are treated with medications. 5%. So that's pretty stunning. They did a national jail survey, and this is an interesting statistic because only so many of the jails responded. In fact, only 38% of all jails in the country responded to this survey. So you have to wonder, like, did the other 62% not respond because they don't offer it? Or I don't know. That's an assumption. But according to the 38% of the jails who responded to this national survey regarding MOUD, 13% initiates and continues MOUD. That's 1-3. And 11% continues MOUD only. They do not initiate, but they're willing to continue. So that's pretty terrible. I mean, it's a little bit higher than the 5% that NIDA cites, but then again, this was only a 38% response rate. What about prisons? Well, there's a really interesting opioid project. I'll give you this resource at the end, but 43% of state prisons report that they offer some kind of MOUD. Now, that kind of surprised me. It doesn't seem like it would be that high. And I know that they're doing a lot more work around this. The Federal Bureau of Prisons has implemented a program where they offer MOUD to people as they exit. I think historically it's mostly been naltrexone, which is good, and I'm glad that they offer that, but it hasn't been full service like buprenorphine or naltrexone or referral to methadone or an in-house OTP. But they are working on it. So they're getting there. And there's a really interesting resource that you can look up where you live in the US if your state offers MOUD. So this is put on by the Prison Opioid Project. You can go to prisonopioidproject.org, and it gives you a map, and it shows you MOUD in prisons and jails by state. And I noticed it's not quite accurate for Utah, although I emailed them, so hopefully they'll change it. But it will show you, if you hover over your state, which state prison facilities offer MOUD and county jails. So, for example, I will hover over the state of Texas, and 0 state prison facilities offer MOUD, and 2 county jails offer MOUD out of the whole state of Texas. So I'm kind of shouting Texas out. Let's look at one more just for another example. Let's go with the West Coast state. We'll do Washington State. 5 of their state prisons offer MOUD and 17 of their county jails. So there's great variability anyway between these states in terms of who offers MOUD and who doesn't. But I know the Federal Bureau is trying to equalize this a little bit. And I know, Darlene, you've done some work with them. All right. So other things about treatment in incarcerated settings, MOUD and HIV, antiretroviral therapy, is really commonly discontinued, especially for people going into prison. And I think that the mindset behind this as well, they're going to be here for a few years. They don't need to continue on these treatments. What is the risk? And obviously, we know that that's not gold standard. That's not the standard of care that's offered to the general population, which is a principle of medical care for all inmates. Brown and Black people more often than white people have their MOUD interrupted by incarceration. I mean, how can you make sense of that? There's no reason for that. It shouldn't be interrupted at all. And it certainly shouldn't be interrupted for people of a certain color. So that's just kind of distressing. There are barriers to MOUD treatment, and we want to know why. Well, one of the studies that looked at these barriers said that the reason why jails and prisons do not offer MOUD or continue it is because of the jail's administrators and prison directors' beliefs about substance use. So they believe that it's a moral failing, that it's a person's choice. They're not aware of the benefits of MOUD. They believe in a behavioral counseling only method or detox method of care. So these guys are just going to detox and then they're going to just be fine. That's all they're going to do. There's also lack of availability of medical care, so no one to provide it. Who's going to do it? Do they know who can provide it? And they also don't have access to the actual medications, possibly. And then the big one is, of course, lack of funding. Maybe lack of legislation. Do you guys have any other ideas on why there would be barriers to this being implemented, other than maybe the biggest one being stigma?
Stigma's a big one for sure.
Yeah, I mean, I think stigma, and then we get the constant funding. But we treat hepatitis C, but if we can just prevent 5 people from contracting hepatitis C and not having to treat them for that, there's your funding. I mean, we argue this all the time.
That's exactly right. And you know what? You bring up such a good point, and that is that the treatment of MOUD is cost saving for correctional facilities. Yeah. The other barrier is patient preference. Actually, some people don't want to be treated. So, they're like, we don't want to be on long-term MOUD. We will decline it, or they don't want naltrexone on release. So, of course, that's patient autonomy, inmate autonomy.
It's interesting, though. Can I just make one comment?
Oh, yeah.
That also comes a little bit from programming. Because I do encounter some of these patients that, especially upon their release, and when you kind of just talk it out with some of these patients and just trying to figure out why they're declining care, even though they've had multiple returns to use, it's because they have been in so many of these abstinence-only programs, and it's just kind of been pushed onto them so many times that you can't be on any kind of medication. And then also it's this linkage to care, which that is something that we really are working on, is they just are like, why should I take anything? Because I know as soon as I'm released, I don't have any options for care. So I'm not going to start on anything. So I think those are 2 good points. And that's where we don't have a lot of solutions to that, except back to the stigma and making sure that we have the same message everywhere where they're encountered, that we want to support all care. Not that we are against counseling, but we do not want to discourage them from seeking all paths to recovery, so that they're not getting one message. And then we want to make sure that we are linking them to care.
That's such a good point. Absolutely. I mean, I've had patients who Well, especially here, if they get transferred, we were able to continue their MOUD in jail, but then if they get transferred to prison, they're out of luck. And I mean, immediately they're on methadone, 100 milligrams, they get transferred to prison. That's it. They have to withdraw from methadone cold turkey. So, I mean, I wouldn't want to be on methadone in jail if I thought there was a chance I was going to go to prison either. I'd much rather get off of it. Yeah, you're absolutely right. All right, well, let's just talk really briefly about harm reduction in correctional settings, which was an interesting topic because it's really not something, it's something we're just barely warming up to in general population, never mind for our correctional setting populations. And let's just remind ourselves of the definition of harm reduction according to the National Harm Reduction Coalition. It's a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. So harm reduction should and can exist in correctional settings. And what does it look like? Well, it looks like providing MOUD. It looks like overdose education and naloxone distribution, providing PrEP, and actually SEPs, like having syringe exchange programs, as well as just providing treatment, actually. I mean, without treatment is harm reduction, right? It's all kinds of treatment, whether it's behavioral, peer-driven, medication, etc. And we do know that harm reduction programs in international correctional settings have been proven to reduce overdose in the setting, reduce rates of bloodborne disease transmission, drug use itself, and improves entry into substance use treatment itself. So we know that it works. We have this data nearly all out of other countries because US lags in this regard. There are syringe exchange programs in Germany and Spain, which have shown zero conversion of HIV for inmates, which is amazing. And they've also shown there's an SEP in Switzerland, which has been around since the 90s. I think, if I'm correct, this actually might be the first known syringe exchange program in a correctional setting was in Switzerland, I think started in 94, where they show drastically reduced transmission of hepatitis C in that prison because of the existence of a syringe exchange. So in the US, though, there are naloxone pilot programs existing around the country, mostly in jails as opposed to prisons. And there are good evidence to back up overdose prevention and utility there. OENDs or overdose education and naloxone distribution programs have been implemented in several states, remarkably California, Illinois, Maryland, Michigan, and New York. And these programs prioritize the risks faced by people who are leaving, like we talked about, and address the needs of their family and friends, which is what Lanette was talking about, right, Lanette? That if you come out and substance use is generational, if we have access to people while they're incarcerated and we can give them access to harm reduction supplies, they may be able to bring secondary supplies to their families. One study shows that opioid overdose education and naloxone distribution led to a 36% decrease in opioid overdoses in the first 4 weeks following release from prison. So it's an effective intervention. So harm reduction programs are beginning to exist in terms of overdose recognition in naloxone. We don't have any advanced harm reduction programs in any prisons in the US, zero syringe exchange program. So we've got some room to go there. What about harm reduction in rural settings? Well, interestingly, 42% of people, more people in rural areas are incarcerated than urban people. So if you're a rural person, you're more likely to spend time in jail or prison than if you're an urban person. And if you're a rural person who uses drugs, you are 42% of you have been incarcerated in the last 6 months. That's crazy. I mean, I don't want to say crazy, that's a horrible word, but that's a high statistic. Lanette, what do you think of that? Like, we live and work in a rural community and you've been here your whole life. Does that seem about right to you, that people are about half the people who are using drugs in our area are spending some time in jail or prison in the last 6 months?
I do. I really do. I mean, in my entire life that I've been here, I would say that that's about as much time as I feel that I put in.
Yeah.
And I see, I see the revolving door, and up until the last couple of years, our resources were pretty slim.
Yeah. Well, there are more risks for people in rural areas as well. Rural people who use drugs are more likely to use drugs IV. This is a subset of people who use drugs in rural areas who are incarcerated. They're more likely to use drugs intravenously. They're more likely to have methamphetamine as their primary drug, and they're more likely to experience homelessness. So they have a lot more risk factors. Also, we know that recent incarceration for people who use drugs in rural areas are associated with more severe substance use disorder in general, higher rates of overdose, lower rates of MOUD utilization, so they're not getting access to treatment, and heightened barriers in general to accessing treatment. So for all the reasons that it's hard to get treatment anywhere in the country, and then add a rural area and barriers to access, there's transportation, there's lack of providers, there's stigma, there's small town, there's generational poverty, there's intergenerational substance use, etc., and higher levels of stigma around addiction exist in rural areas. And they've studied this, and this is true. And, like Lanette coming to a rural area after being in an urban area, I can really see that. I can really sense that. Also, there is a higher rate of criminalization of drug use in rural areas. So whether that's stigma from law enforcement in rural areas, or whether, I don't know what that's about, but that exists as well. And there's a higher perceived immorality and limited understanding of harm reduction in rural areas too, in this country. So there's several barriers, unfortunately, looking at that. And all of this data that I'm citing comes from a 2023 JAMA article that actually looked at 3,000 people who use drugs in rural communities. So it's a really good study. Okay, well, I want Lanette to chat and have time to talk on this episode. But briefly, we're going to talk about, it's been so amazing to work with her. We work together in partner organizations, and we were lucky enough to get a grant from the National Council of Wellbeing to start a harm reduction program in our local county jail, which has a capacity of 60 people, but it normally runs around 40. And so we sat down at a table together, about a year and a half ago, Lanette, and we said, okay, what could we do to bring harm reduction and treatment options to people in the jail? And Lanette and her colleague Heidi were just so instrumental in bringing information and ideas to what we could do after being people who'd actually been in this very jail and live in recovery and work as certified peer support specialists. And we went ahead and designed a program, and we've been implementing it since March of 2022, where we provided trainings for the jail staff to destigmatize substance use disorder and harm reduction, enhance understanding of treatment. We provide groups in the jail that are harm reduction based and peer support driven. And Lanette can talk about that. You were so passionate about that. You're like, this is what we've got to do. And Lanette also really advocated to provide one-on-one coaching from a peer for people in jail. And then we also started providing kits, harm reduction kits. As people leave jail, it's an opt-out offering of a backpack that's full of harm reduction supplies, including naloxone, fentanyl test strips, information on how to link to care, including our clinic, Lanette's program, some safer sex supplies, hygiene kits, etc. And then we really tried to incentivize linkage to treatment. We told people, come and see us when you're done, come and see us when you're done. And we gave them a pizza if they came, which seemed to work to some degree, right, Lanette?
Absolutely.
Yeah. So do you want to tell us a little bit about the groups, like what we've developed and what's worked and what you really wanted to see happen and how it's been going and how we run them?
Absolutely. Well, this project is extra special to me. Like I mentioned before, about 10 years ago, I actually used to spend a lot of time in this facility in particular because, I struggled with substance use disorder. For a lot of years, I started using at a really young age, 10 or 11, full-blown substance use by 13. in and out of detentions. And, I spent a lot of time in the juvenile detention in Blanding and San Juan and then in this jail. And there wasn't any treatment or anything offered in the detention. I used to, just watch a lot of movies as a teenager in there, not any programs or anything. And then same in the jail. And so when this opportunity came up, I was like, man, this would be something that would be just really amazing. And so some of the stuff that, we're doing in there has been like, we go in each week and we do some recovery meetings in there. We go around the groups and they're really strength based. We really try to hone in on each person's strength and talk about like, a challenge and a success that they've had over the week, and, let them talk about like, what strength did they hone in on that week that got them through the challenge, and, let them identify things that worked for them, and, really get their own power, empower these guys to be able to use their
self-efficacy or resilience.
Yeah, absolutely. So that they become aware that their power is like within them this entire time to be able to overcome hard situations and to get through things regardless of what kind of situations and battles they're in. We also take in like SMART tools, SMART recovery tools, which is an evidence-based training. It's a self-management and recovery training. It's evidence-based and for building and maintaining motivation. It's for coping and urges, managing thoughts and feelings and behaviors, and living and balancing life. So lots of tools and lots of ways to be able to do things differently than what they're used to doing there. We also we like to go in and do lots of games, but on our games they have like little questions on them that kind of open people up in there and make them more aware of things that they're not used to, and answer like recovery questions, and just make them have them become more aware of things that they're capable of and always have been capable of. Their whole the entire time that sorry guys, their whole entire time that they the strength they've always had within. Anyway, sorry about that. And then also we get to work with folks individually. And some of the things that we get to work with them individually are individual peer support. We get to use our shared lived experience to, talk to them about things that, we got to go through when we were going, as we were going through our own recovery, how we got through our experiences of being in the jail, kind of, what are they looking at through courts, and, so are they going to end up in recovery court, or, do they have treatment coming up, probation? Heidi or I, both of us have navigated that same, some of those same pathways, is it DCFS or whatever. And so we just kind of support folks in whichever things they end up having to go through. We try to increase confidence and self-esteem with them. We build connection and help break down barriers. We try to talk about like housing options and help build safe social connection before they get out. Set up appointments with, like doctors and treatment and, other agencies that will be helpful for them to be connected to, workforce services, voc rehab, stuff like that. Get some applications and stuff filled out and get those balls rolling for them, and with them, I should say. disrupt power dynamics. There's something about peer supports and us, like there's no power difference between us and them. And so it's just easier for them to relate with us. And so there's this trust that's automatically built between us and them. And so hope and optimistic, the good thing about being from a small community is a lot of the time people know where I've come from. They've seen where I've been. And so one of my favorite things to hear is, if you can do it, so can I. And so, so giving them that piece to take with them. We try to always help reduce isolation for when they come out, and also while they're in, even when they're inside of the jail, there's still freedom that can be had, and there's still a lot of stuff that they can do while they're in there to take care of their well-being. And we like to explore what that may look like for them. And compassion and friendship, we're there for them with a non-judgmental ear, and meeting them where they're at in probably the darkest place that they can be, with zero expectation, and just helping them build up their recovery capital. And so those are some of the things that we're in there doing with them in the jail.
And I can attest, it's amazing. And I love sitting in groups with you and Heidi. I always learn so much, and I'm always really touched by your connection and just your positivity, and you really instill hope and self-efficacy of like, you can do this, and you're so compassionate. And like you said, the power differential isn't there. So people can look and be really inspired and say, well, maybe I can do it. I'll never forget, we were in the men's group one time with Brett, who's our nurse case manager from the clinic, who's also in long-term recovery. And he was told a little bit about his story, and I could just see everyone's faces like, look at this guy, he's here and he's doing so well. And one of the participants in the group just said, I've never met anyone like you. I've never met someone who got sober and went to school. And it just like broke my heart. But he's like, I don't understand that you could do that. Now I think I could do that. And it was so powerful. It was really touching. So the peers are the most important part of our jail groups. I mean, I go every 4 weeks to the jail, and I try and talk about all the medication stuff, like what medications we can use to treat substance use disorder, and how the medications can be helpful, what are they like, and what side effects, and how do you get them. We also end up talking a lot about treatment for hepatitis C and preventing HIV and treating STIs and all kinds of questions. Every question gets put on the books. I kind of love it. And then we have an LCSW who comes every couple of weeks too, and she does harm reduction therapy and MI, and also uses a lot of strength-based approaches. And we had a really great time doing groups at Lanette. Like, our grant ended a long time ago and we couldn't pull out. So we've done this program. This is the small county jail. We didn't get a lot of money for it, but we committed to implementing this. We offered these harm reduction kits to everyone as they exit, and we have some data just since March of last year, March of 2023, and we've offered, out of the kits that are offered, 81% of the inmates actually take a kit with them when they leave. So I think that's significant. And when we ask them what they think about the kit, 34% say that they're very confident in their knowledge on how to use the kit, and 27% say that they're confident in how to use the kit. 31% said they're not confident. So we have work to do there. And then when we ask them if they feel confident that harm reduction supplies make you safer with alcohol and drug use, 29% of the inmates responded that they feel very confident that harm reduction supplies make drug and alcohol use safer. And 30% say they are confident, and then very few say not at all. And then when we ask them about seeking treatment, we ask them an exit question of how likely are you to seek treatment? 29% of exiting inmates who accept the kits and who don't accept the kits, actually, everyone's offered the survey. 29% say that they will seek treatment. They're very likely to seek treatment, and 16% say that they're likely, and 11% say that they're unsure. And when we say, how long will you seek treatment, like how soon after being released, most people say within 1 week. 35% say that they intend on seeking treatment within 1 week. And when we actually track who comes and actually does seek treatment, we've had about a 21.5% follow-up rate in our clinic from people that we've given the kits to. And then I think, Lanette, you and Heidi have had about a 13% rate of people who we've given these harm reduction kits to come to your peer support agency, which to me, that's amazing. That's a 34% linkage to care. So 34% of the people that we've offered these kits to that may or may not actually have attended the groups have actually come and showed up at either your program or our clinic for at least one visit. And we've had quite a few people attend groups. We've had 347 bodies in groups with an average attendance of nearly 10 people in groups per week. And again, it's a jail of 40 people. So that's really awesome. And we have had 81 individual new attendees in the group. So we're really, really excited about this data because it shows that people will follow up. They will attend group. We also were able to connect with Alchemies and get free Vivitrol for people before release. And we've been able to give at least 20 Vivitrol injections just since June of 2023. And that, I think, in part has been successful because during group and then during one-on-one counseling with Lanette and Heidi, we always say, would you like Vivitrol? How about you try this medication before you leave? And we've been able to give that medication to people who otherwise would not have accepted it. So it's been pretty great. And we've really tried to lever the partnership that we have with the peer organization. So key takeaways from treating MOUD. Oh, and of course, we didn't say that, but we offer MOUD in our jail too. So we provide buprenorphine for patients. We provide naltrexone if they want it. And then because we have an OTP in town, we're able to continue methadone. We haven't initiated methadone in the jail yet. We don't have a protocol for that, but we're able to initiate buprenorphine. And we do that on a fairly regular basis. So we're still working, and I think most systems will agree that there are challenges and successes. And we've definitely seen the successes be some change in jail staff attitudes. I don't know, Lanette, what do you think about that? Because you know a lot of these jailers. They've been around since you were actually there.
Absolutely. I have actually seen, the commander was back in my day, the jailer. So that's how far back we go. But I think that I actually feel really blessed to be in the jail that we are. And I've seen a lot of change. And I definitely just think that our jail has, they're just doing so great. And we're so lucky that they're willing to implement all the things that they are. And I think that we're, slowly those stigma walls are coming down and change is happening. And, the numbers that you're reading now are like impactful and a lot better than the numbers that were in the beginning. And, it's good. It's good. Things are good. Things are getting better.
Good. I'm glad. Mm-hmm. Well, we have things that we still want to work on. I know for us in our own local jail, we've been asked for repeatedly by the inmates to provide them with CPR training, which had never really occurred to me, but it became really apparent when we do groups that people don't know what to do for someone who's overdosed. And so we're going to provide CPR training. That's something the jail is committed to do. You and Heidi are going to start offering Inside Out groups, which are jail-specific recovery groups, right, that are evidence-based.
Yeah.
Just
Yes.
a big model. Great. We're going to try and offer more medical presence, more mental health presence. And then, of course, all the things that we hope for, like transitional housing when people get out, a focus on pre-arrest diversion, and then educational and advancement for inmates so that while they're there, they can actually earn credits, make advancements for themselves. And then nationally, what do we need to do? Well, I mean, MOUD needs to be standard for all correctional facilities. It just needs to be part of when you go in that you're offered this life-saving treatment. OEND, so opioid overdose education and naloxone distribution should be standardized. Considering that there's a 40 to 50 times rate of overdose death for inmates, this should just be standard. We should do better at pre-arrest diversion, and there are law enforcement assisted diversion projects that are really incredible and proving to be very effective. Seattle has one, New York has one. And they save money and they are the right thing to do. And then maybe sometime in this country, we'll have syringe exchange services in correctional settings. I know that's probably a reach right now. People can hardly wrap their head around syringe exchange programs for people not in correctional settings. But once you just step outside and realize that it's happening anyway, and we need to keep people safe, maybe that will happen. We need to increase peer coaching and case management in jails and prisons. You are the right people to have in there for all the reasons you just said. And then testing and treatment for all infectious diseases, PrEP. And then we've got to do something to dismantle the structural racism that exists in this country that is putting people of color behind bars and not giving them fair treatment. So that's it.
I couldn't say it better. And I'm just glad that you're sharing this with us. Until next time. Hey, check us out at theaddictionfiles.com or email us at theaddictionfiles@gmail.com. Thank you so much to Ricky Valades for use of his song Awake. Check him out at rickyvalades.com.
Podcasts are for entertainment and education purposes only. Hosts and guests are not responsible for any harm caused by information obtained from this source. As each person is unique, you're advised to seek the advice of your own healthcare professional to treat any medical conditions you may be having. Opinions expressed on this show are those of the Addiction Files and not of our respective employers.